What's up, you guys? It's your boy Miguel giving you your daily dose of radiation. Today's video, we're covering the kind of tools and equipment that the fellow X-ray tech uses at a hospital. So to give you context, I am a night shift X-ray tech. I've been doing it for 4 years. Work a lot of overtime, so I dabble in the day shifts and the night shifts. So, as far as equipment goes, like outside of the machines, the most like medical, I guess, equipment that you could consider some like nurses type, like other medical besides the actual physical X-ray machines, it would be more when you get into fluoroscopy slash involving contrast or stuff like that. So in the ER, especially like just for nights, for us, like if you're curious at nights, the most amount, I mean, there's like a 1% chance, it's never zero, a 1% chance that you will have to do fluoro. There's always a tiny percent chance. Usually we're at a level 3 trauma center, so like we don't have rads overnight. We have online rads. Our regular rads who are in-house, I believe like 5 or 6 p.m. they leave. So outside of that, they only come if it's an emergency, and it usually doesn't happen. But anyways, so for like for babies, it's like the Mickey button slash the, like they replace their, usually it's the feeding tubes, and you'll inject contrast. You'll have like a big syringe with like the little nose tips. Usually those are used when we replace them in the ER. If they come from like a retirement home or from somewhere else, they will usually need the screw on. Like the tip isn't the long like needle. It's like a little screw. You hit the screw in and then you inject the contrast and you flush it out. That's the most like invasive, well, not really invasive, but the most like hands-on type of stuff that we do overnight, which it doesn't really take that long. I mean, most patients who usually get that they're either babies or they're like older people who half the time they end up being like Truman Smith, or people who aren't, they're like special needs type of people. Where, I mean, occasionally you'll have like, I guess, average people who need that for their conditions they have. But most of the time it's special needs. We do that. I mean, if you work in the daytime or you work in the floor department, then you will be involved more hands-on and with way more equipment. Like you'll have certain trays, like for lumbar punctures, you'll have like for enemas require a good amount of material. Like you'll have the gloves, the sterile gloves, you'll have the enema tip, the enema bag, the little donut floaty that we call it. You'll have like a bunch of questions you have to ask the patient. You have the hip injections, you have the arthrograms, you have the myelograms, you have like different stuff that require different trays, and all kind of varies. I mean, they're all the same, the same standard of what you do. It all just comes down to, is it the radiologist? Is it the RPA who's doing it? Which that will kind of determine how you set up certain stuff, how the workflow of the procedure is going to go, because each one of them will do it different. Like you'll see a complete difference from a rad versus the RPA. Like there's a big difference. So you just, that's what time will come. Outside of like just general x-rays, if you move on to, let's say, CAT scan, for CAT scan, I don't do CAT scan. I will one day, but I help out a lot because at night shift, I mean, most of the time there's only one tech over there. So like they get involved with a lot of contrast bottles, because like almost every other procedure is like a with and without, which with contrast, without contrast. So they'll have like the little bottles of ICVU. I think that's what they use at ours. They'll inject those. Depending on how busy your ER is, or your nurses, or depending on if it's a hard stick or not, if like, because they're going to inject contrast into their IVs and stuff. So depending on how, like if it, what's it called? If it busts their IV, there's two scenarios. If it's a hard stick, usually they're going to get the nurse. If they're really busy and they really can't, they'll just send them back, and then the nurse will do that. And like the third case, which usually we try not, from what I've seen, they try not to unless they just are over and they just want to finish it. They themselves will insert the, like with the needle, and they'll kind of like start the IV so they can get stuff going and get their job done. That's usually about the most I've seen them do. I mean, they also do get involved with like, I mean, gastrographin, which we do too, but that's not really, I mean, that's just like the contrast and stuff. They'll do that. I mean, you have cystograms, which we do also in the X-ray department. And then if you move more towards like the ultrasound has a lot of different, like it's their, I mean, they just have like the jelly, and they have like different probes they use for depending on if it's going to be like the rectile, the penile, like there's different type of probes they use, and depending on what they're trying to do, they use different kind of equipment. I will say between cath lab and IR, they use the most amount of hands-on equipment out of all of our departments. Like they have, like the way you see nurses in the emergency room with their vaults of stuff they have, of like nursing equipment to help the patient, that's the same thing when you go into a cath lab, another place, but majority of the times the X-ray tech is kind of responsible for it. So like the responsibility flips. I mean, there's certain stuff like medication and other stuff like that that the nurses will kind of deal with, but like all the other stuff, it's more of a, the X-ray techs are the ones who are more involved in that compared to like the nurses. And like they're more, it's more of a hands-on type of scenario. So imagine like if you're just a regular X-ray tech, you were working in the main department, but like you triple the amount of like hands-on and like more dealing with stuff compared to just the regular main. That's the best way I could probably put it in the general sense for those who are not in those departments, because you work on hands-on with like the cardiologist, the radiologist, or depending on what they're doing. Sometimes you have both the ortho and the radiologist working on stuff depending on what the patient has going on. And they have like all kinds of wires, especially with the hearts, the wires. There's like sterile procedures. There's a lot more radiation involved in those because they're doing fluoroscopy for longer. And essentially they're going like through pipes and stuff like that, your like veins and stuff. So it is way more stuff like that. And they have like a giant little table where they have all the utensils the nurses, I mean the nurse slash the doctor will use, and it's way more invasive. So like if you want to do a lot of hands-on, a lot of stuff, I would recommend pursuing either the main, it's like you're stepping into those procedures just a little bit, and then you go to cath lab and AR, and then you'll start doing way more. Which to some techs, they like that. Other techs, like me, I just rather do x-rays and maybe CAT scan or do both, and it's not as invasive like that. I mean, it all is radiology. It all depends. Some people like that, other people don't. So, depending on what you want to do, There's always that. Yeah, it's been your boy Miguel. See you on the next one.